Episode 21, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome, I'm your host, Dr. Eric Larson. This is episode 21 of The Paradox. Today we're going to be talking to Dr. Anish Koka about public reporting. It's actually a rarely reported phenomenon in medicine. But specifically, public reporting involves the reporting of statistics on hospitals, either as a state function or sometimes a federal function. And so hospitals and providers will have to provide outcome data for, say, their surgeries or certain types of conditions like diabetes or heart disease or strokes. And what this, of course, causes is some interesting phenomena in medicine where it discourages you from taking care of difficult patients and cases. So as you can imagine, if you don't want your numbers to look bad, you'll avoid taking care of the people who are more sick. And oftentimes it's very difficult to tell who is and isn't sick from a 2 mile up in the air kind of look down on the world. To providers in the field who are assessing patients, it's pretty easy to figure out people who are going to be at high risk and those who are not. And so if someone is a higher risk, although they may be stratified within the reporting system as sort of the same kind of level, you're going to be discouraged from taking care of that patient because the likely outcome is going to be worse, and therefore your institution is going to look worse, or you personally, as maybe say a surgeon. And why that matters is not because most patients look these things up, but it's because that these are looked up and used by the government when it comes to payment. And they'll penalize institutions which could be worth millions, tens of millions of dollars, sometimes even hundreds of millions of dollars. And so the stakes are very high in this sort of game of reporting. And so what happens, of course, is that it discourages people from being cared for. Oftentimes the people who have the least ability to protect themselves, because obviously if you're someone who is important, let's say, the president or some senator or someone who gets sick, everything's going to be done for you. Public reporting, no one cares, but they're absolutely going to care about outcomes if you're just Joe Schmo off the street. And so for a person who is not in medicine, this can't be any more important. So anyway, we're going to talk about Dr. Koka, who has written extensively on this and other subjects in healthcare. He has a co-host of his own podcast, which we'll talk about in a little bit during the show. But a couple housekeeping things to take care of first. As always, you can go to patreon.com/theparadox, and there you can support the show. All the money raised there goes towards the production and the promotion of the show. I appreciate the patrons not only for their financial support, which helps pay for all this stuff, but also for the encouragement. As you probably know, there's been some difficult times in my family, and so not only have you, the listener, but those patrons have provided a lot of very encouraging support, and I appreciate that. So I'd encourage you to go there and sign up and become a patron. That will allow you the opportunity to get a hold of some bonus materials, not only some interviews I've had in some other podcasts, but soon I will be producing new content, and I'm going to poll all the patrons, so heads up, guys, to find out what kind of things you'd like, whether it's a 5 minutes rant on something once a week on medicine or whatever you guys are interested in hearing from me. So I'll start providing that pretty soon, and so it'll be an added bonus for those who are supporters on Patreon. That's patreon.com. Show notes for today's show can be found at theparadox.com/021. I can't believe I'm actually all the way to episode 21. 21 weeks into the show and going strong. I appreciate all the referrals that people are making and sharing with your friends. Clearly, show is far more popular than I anticipated it being at this point, although I'm far from going viral, as my late son would always tease me. I definitely appreciate all the people listening. So without further ado, Dr. Anish Koka and public reporting. Enjoy. Well, hi, I'm here with Anish Koka, who's a physician out in Philadelphia, the area. He's a cardiologist, and he is a co-host of the Cod and Coca Report. I'm not sure how you got second billing, but I suppose Michelle just claimed it was because he came first in the alphabet, I suppose, right? But,
exactly right.
He writes extensively on the healthcare blog and medical economics. You can find his pieces on healthcare sort of all over, and he's active on Twitter as well. And I have discovered that Dr. Koka is not active on Facebook. So that's a good way to get a hold of you. But thank you so much for being on tonight.
Thanks for having me.
So today, it's interesting. I tell people all the time that when I started this podcast, this is going to be episode 21. I, for one thing, didn't think I had more than 4 or 5 episodes in that I had in sort of in the can. And then it wasn't before long, you start running into all sorts of different subjects. I know you've got a healthcare podcast as well, which is really excellent. I'd highly recommend anyone to listen to as well. But do you find that too, where you think you've got like 4 ideas, and then before you know it, you've got 8 or 10 because there's sort of pop up?
Yeah, and it Twitter kind of does that too. It's like it's very hard to focus on any one specific thing because seemingly every 15 minutes there's some other issue that's being raised. It's like, oh man, like I have something to say about that.
Right. I mean, that's what I think has been great about the podcast. It is a great avenue. Well, like I've said before, I have very few artistic talents. I can't draw. I can't sing. I can't write really well, but I can talk okay, and I've got, I think, interesting take on things. And so it certainly gives you an avenue to get to teach people. I mean, we don't focus on physicians here, except the fact that there are 2 docs on, but the focus is on just medicine, which I think is, to even the layman, is pretty interesting, especially the things we're talking about, which I absolutely affect everybody because everybody at some point has contact with medicine. Yeah,
no, absolutely true.
Today, I want to talk to you about one of the pieces you've written. And again, like I said, you've written quite a bit. So I'd recommend people just check you out and kind of find all the things you've written. You wrote an interesting piece on medical school. We won't talk about that today. We're talking about public reporting because it's something that's not, I don't think it's very well known to most people. I think most people recognize there is public reporting of consumer, ratings of things. If you go to Amazon, there's a 5-star rating, and certainly that's becoming more prevalent in medicine as well. When you see if you try and search any physician to try and find something, like the 12th hit, if you're lucky, is going to be the practice. The first 10 are going to be, these whatever. I can't even think of like healthcare.com and all these sorts of different rating systems that always have like 1 rating on you or something.
Right, exactly.
But public reporting is a little different. And so why don't you just kind of go into the background of what it is and then why it should matter to someone who doesn't know anything about it?
Yeah. The desire for public reporting goes back a long way. There's this idea that there's a lot of healthcare being delivered in the country, and we have to find some way to signal to the consumer, signal to the patient, what is high value and what is not. So, so as far back as 1984, when CMS used to be called Center for Medicare and Medicaid Services, is currently called CMS. It used to be called the Healthcare Financing Administration, or the HCFA. It started to publicly report hospital mortality rates of Medicare patients. And, the agency identified 250 hospitals or so that were outliers with regards to death rates. And they just put that out for the public to, for public perusal. And, as is the common theme, though they attempted to adjust for a variety of risk factors, it was heavily criticized by the hospitals and the physicians at the time. And eventually they just stopped publishing the data. But there's clearly a desire and a demand for some type of reporting of providers and of hospitals. And so, the next iteration for it, and I will posit, and I'm fairly firm in this belief that part of the big push for it is not necessarily from patients, but I think one of the major pushes is from folks that are interested in bending the healthcare cost curve. So, New York and Pennsylvania, I'm a physician who's been who practices in Philadelphia. New York and Pennsylvania followed suit, and they started reporting public cardiac surgery outcomes. And it's specifically the Pennsylvania charter, for instance, was the Pennsylvania Healthcare Council, and they were specifically charged with improving the quality of care and restraining healthcare costs.
Right.
And so you have these two kind of they can be competing. They can compete against each other, and they have these public kind of every year they put out these report of what expected mortality should be based on risk of patients that are being done, and what and then the public then can see that. Mostly the public ignores it, but what happens is that some journalist in some local paper will pick it up and pick you up as an outlier, and then scream headlines saying, "Aha! This hospital down here is an outlier in terms of this, that." In order to generate a lot of buzz. So that's kind of, so public reporting now is everywhere. Now, the most recent iteration, I guess, would be what ProPublica did. ProPublica took a bunch of data that's publicly available, and using some proprietary algorithm that they have with some input from a bunch of healthcare policy folks, came up with a surgeon-specific, kind of ranking system.
Right.
And they put this all out there as well. And the video, I mean, for anyone listening, I mean, physicians especially who are listening, the video that ProPublica put out, in terms of the teaser trailer for, hey, use this public reporting system to figure out where to go. It's like this ominous soundtrack about 400,000 people every year die because of the medical system, and how will you figure out whether where to go? The decision is life or death. And
Right.
here we have this like beautiful system that tells you where to go. So that. Sorry, it's a very long answer to your question, but that's kind of where we're at with public reporting. You have all sorts of folks that are pushing out these ranking systems of healthcare systems for the public to kind of peruse and make decisions on healthcare based on that.
Right, and so it becomes very complicated because it's not like. I guess when you're looking at outcomes, it's not like ranking a Ford Explorer or a Toyota Prius or something like that, because you don't have something that's mass produced that has reliable sort of components, and you have expectations for how everything works. Right. Because we're both physicians, and everybody is completely different. They respond differently to medications. Their disease process presents differently. They have totally different backgrounds, and so to try and stratify risks and outcomes is really difficult. I mean, I can't stress enough how hard it is, and it's not like it's not possible. There is a way to sort of figure out what is high quality and low quality healthcare, I suppose. But to get very specific, I think it's probably an impossible undertaking.
Yeah, no, I agree. I think it's very, very, very hard to do, to get granular enough, as you're saying, to truly figure this out. And so I know a lot of the policy folks think that's an easy out, and
yeah.
But it's incredibly hard. I think it's incredibly hard to risk adjust, and you have all sorts of issues that come to bear, years of training, volume, the available support team, meaning suppose you're the greatest surgeon in the world, but you have, an critical care anesthesia team that perhaps isn't as good. I mean, it's it's just super hard to figure out. And the thing is, Eric, we used to have a fairly reasonable mechanism to sort out how and where to send folks. We had these network of independent physicians who, are very invested in their patients and their patients doing well. Not only because they care about their patients, have, these deep 10, 15-year relationships with their patients.
Right.
But it's sort of the simple matter that if you have a lot of bad outcomes, if you send your patients to somebody who has a lot of bad outcomes, why will other people come to see you, right? So you're super, super invested as a small independent group of physicians in terms of your patients doing well, and so it behooves you to know who is very good at doing aortic valve surgery. It behooves you to know who is especially skilled at placing a left ventricular lead for resynchronization therapy, or it behooves you to know that, okay, this person is skilled, has a terrible bedside manner, and when there's a problem, and the patient calls that office for a problem, they get nowhere, right?
Right.
Again, so that's the type of granular information that your local doctor who has a shingle out on the street, that's the kind of information that he has. That you have access to if you go to see him and have him be your guide, right? The idea that you're going to replace that type of information with some stupid score based on publicly available mortality statistics, and what the age and the morbidity of the patients are that are coming into a certain surgeon. That seems a very, very heavy lift.
Right. And so I think to give the listeners an idea of what we're talking about as far as scoring system. Yeah. As you can imagine, you could have a super specific scoring system, let's say 1,000-point scale. Well, that'd be almost impossible to sort of score someone. It takes so much time to actually score and figure out the exact, where you are on the 1,000, you're certain to die, and 0 you're not. And so what every specialty has, or many researchers, when they do papers, they try and evaluate and give you an idea, sort of overall sort of mortality risks based on the patient, maybe their liver disease or their cardiac disease. And so I'll just give you an example when it comes for anesthesia. So we have classification systems for our patients. Mm-hmm. They're called ASA, which is the American Society of Anesthesiology. We have basically 1 through 6. So 1 is someone who has absolutely no disease at all. And so that's the totally healthy person that comes in and, they're just for a well check or something, or maybe they just have their appendix they need an appendectomy. They might be a 1. So 2 is someone who's got a disease that doesn't cause any problems. It's something that's controlled. Maybe they have high blood pressure or some gastroesophageal reflux disease, or something like that. That's well controlled medications. Then you move up to the 3rd, which is someone with a severe systemic disease where they've got poorly controlled diabetes or high blood pressure or something. And so right away you can recognize, if you know nothing about medicine, there's quite a big step between 2 and 3, right?
Right.
So now you go to 4, and 4 is someone with something that has a disease that's systemic, like diabetes or something. That is a constant threat to their life. So there's potentially could die at any moment from this. And so again, that's a gigantic leap between 3 and 4. And now you go to 5, and that's someone who's basically about dead, and they're almost certainly going to die.
Right.
And 6 is someone who's brain dead. So and that's how we actually, and so that's how we score all of our surgeries in through the CMS. And so that they actually use the ASA status. And so you can see that's not a very good way of figuring out who's taking care of the tough patient, because as you pointed out, when it comes to the difficult patient, there's someone who's got a couple systemic diseases, and they're it's going to be a tricky case. Let's say a tricky surgery. That local knowledge that people have, like, oh, this is the surgeon who can do this and can pull this off. There's a good chance this person's going to die, but it's 100% chance they're going to die if it's not the best person who I happen to know who it is. And so then that's where we get into the point where now you have these perverse incentives for the healthcare system or the hospital or the surgeon or the the care team because of these scoring systems. And that's sort of the part of the public reporting that is the insidious part of it, right? That you talked about in your paper.
Right. No. Yeah. I mean, it's well said. I mean, it's just, it requires somebody like you, Eric, to kind of delve a little deeper than the the kind of these categorical responses that we currently employ. So, I mean, the statisticians, I don't know, I have a tough time understanding a lot of what the statisticians seem to be saying, but the statisticians would seem to say, well, the problem is categorizing. You shouldn't categorize. But it seems to me like, Frank Carroll is one of the statisticians who frequently is on there talking about, all the information that's lost when you categorize. And it's what we're saying right now. I mean, we kind of intuitively understand that.
Sure.
I think any experienced clinician kind of goes beyond just whatever categorical risk scores there are. But it seems like, why are they trying to, essentially they're trying to recreate Eric Larson in the scores, and they always seem to fall incredibly short of doing that. So.
And the whole point of this whole thing, so the point of public reporting, of course, is to at least ostensibly is to allow people to have an idea of where they're going to get good healthcare.
Right.
But of course, ultimately, we know that that's not really what happens. Right. I mean, so the reason this is a problem is because now suddenly there's this incentive for the hospital to not take care of people who are potentially going to make their numbers look bad. Right. And that goes for the surgeon, and that goes for, the other care teams. And it is not difficult for me to look at an ASA3 person, let's say, that's that third stage where someone's got something that's not well controlled, and say I know one who's very sick ASA3, and I can see a very healthy ASA3. And so I can tell you which ones are not going to do well, which ones are going to do well. Although using any sort of classification system you want, it's going to look kind of the same to the statistician who's wherever.
Right.
And so what happens, of course, is that it's going to cause real problems with patient care. Right. And so that's and the reason that the hospitals care so much is, I think, not real. I probably should be careful how I say this, but I don't think outcomes are necessarily what hospitals are so worried about. They are worried more about the consequences of the perceived outcomes that they have.
Yeah, right. I mean, the game now is, it's interesting. The U.S. Well, no, let me say first that this is why the public needs to care about this. The public needs to care about this because there is clearly risk avoidance that takes place, whether it be subconscious or consciously, by the operators that are going to get dinged if they have a bad outcome. So if you're an operator that's going to have a bad, that is going to get dinged by something, because your outcomes are being publicly reported, say, you are simply put not going to have the same attitude towards taking care of super sick patients as you did before. And guess where the biggest gains are to be had? The biggest gains are to be had in terms of turning things around for a patient. The biggest gains are to be had not in your ASA class 1 super healthy person. This person is going to do well almost regardless of what you do. No
matter what they do, yes.
Yeah, the biggest gains are to be had in those patients that are very sick. Where if you don't do something, that their life expectancy is 3 days, but if you do something right, their life expectancy could be 30 years. And so it's kind of insidious that it actually harms the most vulnerable and the sick among us, and that's the story that I wrote.
Right. So why don't you go through that story, and because I think that illuminates sort of the whole situation that we're talking about. Because I think we're sort of giving sort of almost too broad a picture. And so let's just talk specifically why public reporting matters, because it absolutely influenced this story that you wrote about.
Yeah, I had a patient, a real story, and I got permission from the family so that I could tell the real story. And it was a gentleman that came in with he's a dialysis patient who came in with aortic valve endocarditis. And he was discovered pretty rapidly. And then 24, 48 hours, he was decompensating. And it was discovered within that time that he needed his valve fixed. There was no other treatment. His mortality was 100% unless his valve was fixed. And because I've been practicing, for about a decade or so now, or close to a decade or so now, for me, it was fairly automatic. This was a gentleman who needed his valve fixed, and, call a surgeon. And surgeons would take this man to the OR and try to fix his valve. Now, he was in his 50s. He had a good quality of life, reasonably good quality of life before, would play his guitar, go out to dinner with his wife. So yes, he was on dialysis. But this wasn't somebody who was at a nursing home, with a feeding tube where, there was no quality of life here. This was a guy who was pretty darn functional, had a good quality of life. And he has this acute problem that will kill him in a matter of 3, 4, 5 days unless you do something. And, remarkably, I could not find a surgeon who would operate on him. I called, surgeons at the institution where he was at wouldn't operate on him. The larger, higher volume institution that was in the city wouldn't operate on him. I called Johns Hopkins, and Johns Hopkins said, "Nope, we won't operate on him now." And in talking to one of the very senior cardiothoracic surgeons about what's going on, he said, "No, without a doubt. Look, this is a function of public reporting." I think I have a quote in the blog from him that says that. Society has to understand that there's consequences, and the consequences of public reporting are this, that you will turn away some folks that are super sick that have a high mortality. I mean, I think he said specifically, he's a casualty of public reporting system we have in the United States.
Yeah, a literal casualty.
Yeah, and it's terrible. And and Joe was his name, and Joe died. Joe died.
Right.
Within days of all these turndowns. So yeah, I think, and we're not going to see. Our job as physicians is to look out for the vulnerable, to look out for the sick, right? And I don't think the vast majority of folks are listening or caring about this, because the folks that are really getting impacted are the very, very sick, the very sick folks that are the small minority. Also, the other thing that that's upsetting is that if it was somebody with connections, if it was some affluent person who had,
right,
I mean,
was the president, let's say.
Yeah, absolutely. I mean, if that person was on dialysis and whatnot, that person, nobody's going to turn that person away, right? So that's what was especially upsetting. We want to pride ourselves as equal this and equal that, but the long and short of it is that, look, if you're average everyday Joe who's very sick and has a high morbidity, high mortality, look, the health system isn't going to take one on the chin for you. Isn't going to take the chance of taking it on the chin for you. So I think it's terrible. So I do think, look, it's not that I think that the medical care is perfect. I think there's continuous improvement that can happen. It has happened, and hopefully will continue to happen. And look, there's a lot of variability of care that exists in the United States, and some of that variability in care is subpar, and we have to, as a medical community, figure out a way to try to kind of lift all these boats so that everyone, we can try to improve the kind of care that's given. But we have to do it in a way that isn't pejorative, that actually ends up harming the folks that most need it. So I think some system of reporting that isn't public is probably the way to go. Some panel of folks that have some panel of folks that you have to report to in terms of what happened and why this happened and whatnot. That would be a smarter approach. But unfortunately, we've kind of abdicated all of this to this, this public reporting model, and it's like dogma. I don't understand it. I don't understand it at all.
Right.
It's like, fine, we tried it. It's ridiculous. It's associated with bad outcomes. It's associated with risk aversion. There's surveys that are done by a number of folks, and they self-report. The surgeons report, yes, if there's public reporting, we will act differently. In New York State, when they did this for coronary interventions, the number of people who were presenting in shock, who were being intervened on, dropped dramatically, right?
Right.
And once they excluded, once they were like, oh, okay, this is maybe not a good idea. Once they excluded that, excluded the diagnosis of shock when we were coming in, that suddenly now, they started doing more of those folks. I mean, this is incredible stuff, right? I mean, people have a cow when you talk about, oh my God, fee for service incentivizes people to do this and that. You literally have a system in place that is incentivizing doctors not to take the sickest people sickest, most vulnerable patients to and give them therapy, and everyone is just like sitting on their hands, being like, "Hey, well, things
Right.
happen."
Well, and I think an important point to state here is that we're not talking about feudal cases. We're not talking about this guy's got to get his valve done, but he's going to die no matter what we do. But we're just going to do something because we can do it. Like that was what was it Obama who was talking about all the unnecessary surgeries done and all this. Right. I mean, this is not what we're talking about. I mean, there is definitely a line, which is why you want physicians who are capable of saying, your chance of surviving this is very low. And if you do survive, your recovery is going to be 6 months in the ICU, and you get a trach, and you get all. So your quality of life will be very low even if this works out well for you. And then people can make informed decisions of whether they proceed with the surgery, or, for instance, or whatever, or the treatment. But we're talking about things that are pretty straightforward. Like someone comes in, as you said, in shock. So this is someone who's had a heart attack, basically, or having a heart attack, and they need someone to put a stent in their artery so that they get blood flow to the heart, and that saves their life. But it can be risky, right? And so the reason that public reporting is in my opinion. So I'm going to play your partner's part here.
Yeah.
And the only reason that hospitals really care, and I would say, and most people care at this point, is now those mortality scores and your outcomes are reflected by how much you get reimbursed from the government payers. And to my knowledge, it does not affect your third party paying for commercial, but where you lie on that mortality morbidity scale will absolutely affect how you are paid by the government.
Right.
And so there's a tremendous, and it doesn't just affect like just the surgery, right? It's all your payments to your hospital. And so so you try and maximize, or I should say minimize, your risks to poor scores. There are stories of hospitals that are pushing anesthesiologists to change their scoring for patients' health, right? And so, there's nothing wrong with that in the sense that the way we score 1, 2, or 3, like I was talking about, I mean, it's somewhat subjective. If someone's a 2 or a 3, there's also designation for E for emergency. Well, what is an emergency? Well, a surgeon thinks everything's an emergency. It's an anesthesiologist can say that. But there's a really an emergency? Is an appendectomy emergency if it has to be done within 24 hours? But if you put an E on the end of it, now that helps the hospital's mortality morbidity scores. So it means everything to the hospital. And so they have committees that might form to try and make sure you're scoring properly. Because their payments are dependent on it. And so I wonder in many ways how much physicians would care about the public reporting if they weren't being, there wasn't such external pressure on payment.
Right. Yeah, no, right. I mean,
because then the patients are, if the patients and their physician, who their primary care person or whatever, whoever it is that recommends that look, and like you said, your reputation as a primary care physician is entirely dependent to not only how well you treat that patient, but who you send them to when there are things that are outside your specialty, right? If you send people to the wrong physician all the time, well, they're not going to like you either, no matter how great your bedside manners.
Right. No, exactly right.
And so I wonder if it's because we have this goofy system that the public reporting is actually an issue. And do you think it'd be as much of an issue if it was, if there wasn't this is like 10% penalty for Medicare payments?
Yeah, no, I mean, I think, this overarching theme, like I said in the beginning, the reason public reporting kind of rose from the ashes is because it's a cost. It's an attempt to bend the cost curve. I mean, they may dress it up and say, "Oh, it's for quality, and we want to we want to just all we want to do is reward the best, the best hospitals and help patients, and it's all about quality and safety." But really, I think everyone knows that it's really about cost containment. So I mean, and the only tools that folks that think in a in a 3-dimensional world, they think in 2 dimensions. the only tools that they have is what we're talking about, is pay for performance, is is, well, we can measure this and this. And so if we can measure it, then we can base quality off of it. Right.
Right.
And no, I think absolutely there's this giant amount of momentum towards ranking folks and valuing folks because they want to attach payment to it, like you're saying. And if you don't rank folks, if you don't measure things, if you don't count the beans, then how the heck are you going to then attach payments to that? And so I don't know how that's going to get. I mean, I agree with you. I mean that is the way it is, and there are movements afoot to try to break that. But man, it's there's certainly a lot of people that aren't interested in that.
Well, and I will talk to people oftentimes about when it comes to CMS, and that's Center for Medicare and Medicaid Services. I mean, if you look even at medical education, how it's changed significantly over since you and I trained, and even before we did. You talk to someone who's been in practice, let's say 30 years, and they trained in the early 90s in medical school.
Right.
They were, as a medical student, they were doing all the notes. They were actually taking care of patients. Now they were under the guidance of a resident, usually someone who's in that specialty, but they were actively involved in the care of patients. You fast forward to today, and the medical students are. They're sort of the fly on the wall, and it's not anything that they've done, but it's because of the system that I've always felt, and this is just pure conjecture, but I feel like that CMS was always looking for ways to cut spending, and that they would change the rules and hope that people would be just slow adopting them. and so for instance, you'd say, well, no longer is that medical student note adequate for documentation for what the patient's for the patient's care. So now the junior resident has to write it. Well, some medical schools might be a little bit slower adopting, or private institutions, and so they get dinged for their payment for a year or two, and they kind of catch up. And then they say, well, no longer the junior resident, now it's got to be the chief resident, and then before you know it, it's now the attending. And so before you know it, what the medical student is doing is completely inconsequential to the care of the patient. Their contribution is really tangential at most, right?
Right.
And so now they are not participating in the care at all. And it's not because of anything that they can't do, because it's more just a reflection of the work needs to get done, documentation needs to be performed. And now everything's just been devalued. And so just from a time standpoint, if you're chief resident, you got to do all this stuff, this work, instead of overseeing a bunch of things and guiding people. Now you're forced to do all this sort of busy work, I guess you'd say.
Yeah.
Whereas,
Eric, you're not saying that beautiful 12-page epic note with the review of systems and like every possible documentation thing. You're not saying that doesn't have value.
Oh, I think, and I do think it has value. What's interesting about, I know. What's interesting about that is now we produce those 12-page H&Ps, right? Yeah. But we do it in a 5-minute visit.
Yeah.
With the AHRs. Right. And so the quality of that 12-page is actually, it's not worth anything, because we didn't establish any rapport with the patient. We didn't really ask we asked the questions, but maybe on a survey form they filled out in the lobby, or they talked to the MA. And so there's
right. So I really, really despair for the profession. I mean, we think we're advancing, but what we're really doing by, and you're right, we've stripped medical students out of the process. Forget medical students. We've stripped residents from the process.
Oh yeah, absolutely.
It is pretty common that I walk through ICUs now, and the only folks I see are NPs.
Right.
Right. And it's because, we've made the job one of being, clickers, and, we got to reduce variability in care. So, click, and, put this protocol in, and I just put this order set on. And when you make medicine order sets and clicks and, making sure your discharge summaries are things, and making sure your messages are checked off, and, then everyone's happy with you. If that's what you make medicine, then you are easily replaced by a provider.
Well, right.
You've devalued, being a doctor. So.
But from a patient standpoint, the reason you should care is because you have lost the person who's doing the diagnostician, the person who's going to figure things out. Because if you're just following an algorithm,
Yeah.
all the time, you're not going to get good care. Without a doubt. I mean, there's no question, because, and I don't know why people have such a hard time grasping this, because when I say, everybody's different, they respond differently to, medicines and stuff. They're like, yeah, sort of. But I will say, if you do go to an anatomy lab, it's a tremendous amount of variation you see in where, nerves are and muscles connect and how, and people are like, really? I'm like, well, if you look at people, no one is surprised that two people don't look alike on the outside.
Yeah.
Yet for some reason, we think everybody looks exactly the same on the inside. It's bizarre, really. I mean, if you think about it for a second, you're like, oh, well, of course it makes sense that everyone's different on the inside too, so you can't possibly have any sort of system that is going to treat everybody the same, because everybody is absolutely not the same.
Yeah, no, absolutely. But the problem is, the game is, we're so far gone, meaning we're so into cookbook medicine. We're so into, the latest sepsis guidelines, says we should give everyone 30 cc's per kg of, making that number up, of fluid, so meaning it doesn't matter to be like a good doctor. It doesn't matter if you're the resident or the NP or the PA or whatever. Like, your job, once you see the heart rate is over 100 and they've met the 2 out of 4 SIRS criteria and the lactate has automatically been ordered and it's 2.4, your job now is to initiate protocol X and do 12 things. And literally, it doesn't matter. It doesn't matter if it's the NP doing that, the PA doing that. Now, you would hope, that we were still living in a world where you had somebody who was using this their large experience, their understanding of physiology, their understanding of anatomy or what have you, to know that, like, well, this person has an EF of 30%, and maybe, just maybe, when we resuscitate this person for sepsis, we should resuscitate them differently than the 30-year-old with a pneumonia.
Right.
And again, all that is lost. It's like, well, the lactate was 2.2, so that's why we initiated large volume resuscitation. It's like, well, okay, good. He's in pulmonary edema, and I guess that's cardiology consult for me. Great.
More business for you. Well, right, and you'll see definitely far more consults and use of specialists.
Right.
Where before people they would be able to kind of figure things out on their own, because that there's some common problems, and it's always difficult, I think, if you're looking at it from an industry standpoint. I hate calling healthcare an industry, but it is. I mean, in many ways, right? It is very difficult to look at it and say, well, there are absolutely some things that make things safer. For instance, if the pharmacist always filled out exactly what you write down, maybe you were tired or your handwriting was bad, which happened all the time, right? And then someone got the wrong medication, and so by having electronic, prescriptions, and there are ways of eliminating errors that could occur.
Right.
And so, without a doubt, those things made things safer.
Yeah.
The problem is that was then used. Those sort of solutions were used in mass to try and fix all sorts of problems. And I think there are some problems that can be fixed with algorithms, and having an idea, for instance, like ACLS, right? We all kind of know how we sort of approach a code when someone's heart stops, and those, again, although even there is definitely some problem solving that occurs, right? Why the heart stop, right? You have to figure that out, because if you just kind of do the same thing every time, you're not going to fix. You might not providing adequate care, but there's a balance, right? Like anything, there's some advantage to those sort of algorithms, but the system is, it sounds like the Borg or something, the system, but these healthcare systems are so in love with these, because it makes it, if they can make things standardized, it's a lot easier for them to figure out to replace people, and then also just to standardize the results, which is probably not the best for patients.
Yeah, no, absolutely. The interesting thing, in terms of public reporting, is that the folks that probably, I at least of what I know of it, the folks that probably do the best job is probably the U.S. News and World Report. In terms of their philosophy is not necessarily to shame you, right? that's the ProPublica approach. The ProPublica approach is like, this is terrible.
Right.
My God, this is like
these are the people who kill you, right?
yeah. This heart failure program that is located in the worst socioeconomic, the poorest area, they have the worst outcomes. And oh my God, clearly this is like well outside of our expected mortality.
Right.
And then they'll find some disgruntled like employees who will say, "Oh, this person was arrogant, and this cardiologist was driving a Porsche." Oh my God, I'm putting together ProPublica and the New York Times and stuff. But my point is, there's an approach to it by certain areas of healthcare journalism that is very much into shaming, and I think that is just fundamentally bad for so many different reasons. Meaning, if you were good enough, like if Michael Jordan is allowed to be arrogant and a prick because he was so amazing. Now, if ProPublica had such an amazing algorithm that like it was like spot on, right? Maybe they could run around being that arrogant about it. But they are just so utterly bad. Like, I mean, I don't know how many people. Saurabh Jha, a radiologist who writes a lot. He wrote a fantastic piece when ProPublica's Surgeon Scorecard came out. I'd urge anyone to read it, and just kind of tearing apart the nonsense that ProPublica does. But there's that approach, I think, is far inferior to what the U.S. News and World Report does, which is just identify the best and say, oh, look, these are outliers that look to be much better. The other reason the U.S. News and World Report, I think, does a better job is because almost a third of their score is based on reputation.
Right.
So
where are you going to refer?
Yeah, exactly. So it's based on a bunch of doctors saying, yeah, Cleveland Clinic is awesome for this surgery, right?
Right.
So they're the score integrates your local knowledge.
Yeah.
Integrates the local knowledge that exists about who's good and who's bad. And that's that's probably not a bad way to do it. Though I would argue that, why do we need the extra data points if that's probably the most important thing
right
of it all? So
right. I think a good parallel to this is if you look at education. I think we all, just like I'm here trying to talk about state that people are different as far as how well they can take care of themselves and how they respond to treatments, and that the gradation system is very complicated. It's exactly the same in education, right? I mean, you could have a fantastic teacher in a situation where with a classroom of students whose families are a disaster. They're maybe not eating enough food, and they're coming in hungry. They're not sleeping. There's gunfire outside the house, whatever. And so there's no way that kid is going to do well. And any scoring system you have is not going to be fair.
Right.
And to try and grade between teachers, well, I think it's oftentimes it's more a reflection of what's going on elsewhere. I mean, there's no question there's a difference in quality of teachers, but to try and use standardized scoring or some sort of blunt measure is probably not the best way to figure it out. But if you talk to people whose kids went through that school, they're going to know who the good teachers were.
Right.
I mean, for the most,
right.
You talked about 10 parents, they're going to know the bad ones and the good ones that you could have. I don't know what the state scoring system is, but you don't really care about it because with the local, like you said, the local knowledge of people who went through the school or knowledge of the school,
right?
They'll know the right places. And so that's a far more effective way. But of course, with funding that comes from outside of either this would be from usually state funding or something. And so they feel there has to be some sort of way of scoring things for payment to punish people who are bad. But it's because the money comes from so far away from people who have no way of having local knowledge that there's just no adequate way that they can actually do that. Similar to from DC trying to send money to a hospital in Billings, Montana.
Yeah, exactly. And as soon as that happens, I think you get all sorts of gaming and the payers the payers in the sense of responding to signals that they're being kind of taken for a ride, and this is their way of pushing back. It's just a silly system that Dr. Akkad is constantly trying to completely blow up. I just want to blow it up a little bit.
He's willing to go in with a nuke, I think. And I don't know, maybe that's the way to do it.
Yeah.
I'm not sure. Sometimes nibbling may not work very well. So I appreciate you coming on and talking about the public reporting. Super interesting. I hope people understand kind of what we're talking about, because again, it absolutely affects, if you're not someone who's really sick, I guarantee you have a relative, a great aunt or grandfather or someone or someone ends up in the ICU. These things are really important. And if you have people who just throw up their hands like, well, sorry, there's nothing we can do, when there probably was something they could do. Well, that's more important than ProPublica saying, oh, this place is terrible. If there's some place that's that's just willing to just give up right away. And that's why this is super important. I don't know what to do about it. I can't offer any solutions. Sometimes you're like, there's a legislative, like, we just changed this law. Here, if you got rid of public reporting, I still think CMS is going to they're still going to have some sort of system where they're going to penalize, or because they want to try and save money. Like you said, bending the cost curve. They want to try and find ways to people to pay less.
So. Yeah, it's certainly a vexing problem that does not have any easy solutions. But,
so for listeners who are interested in reading more of your stuff, what's the best way to sort of find your writing?
I guess Google. If you
well, they just end up with healthcare grades.
Yeah, exactly. If you go to if you go to the healthcareblog.com, I think there's a author search there where you can search by name.
And what's your Twitter handle?
Oh, my Twitter handle is Anish_Koka. So ANISH_KOKA. So, and
that's probably the best way, right? Just kind of, because you sort of link to your stuff and then other things there. And
right, exactly.
Since you're a Twitterer. Well, again, thanks so much, and I recommend everyone catch the Akkad Koka report. I've had Akkad and I've had Koka, so I don't know. If you guys had another person, I guess I'll have to have you on too. But, thanks again so much, and I hope that we can maybe someday figure out what better way to report things.
Yeah, absolutely. Eric, thanks for having me on. Appreciate it.
My pleasure.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.